Hi, welcome everyone to our last session of the Cog Quality Infrastructure series. Thank you so much for joining me on this walk through Cog Quality Infrastructure. My name is Jennifer Wagner. I am the Director of Rural Health Initiatives at Convergence Health. For anyone that this might be your first time joining us, I want to give a quick background to the infrastructure and what we've been doing through this series. So in March of 23, National Partners for the Rural Hospital Flexibility Program convened a group of critical access hospital staff, state flex programs, hospital and healthcare association staff, and several quality consultants and different quality program subcontractors for the purpose of identifying attributes of a strong quality infrastructure in rural and critical access hospitals. I want to give a special shout out to and credit for this work to the Federal Office of Rural Health Policy. They fund the FLEX program, the FLEX monitoring team, the National Rural Health Resource Center, and Stratus Health. These organizations have really developed a well-informed and valuable resource and data source for our rural hospitals and the programs that support them. And these people, they really truly understand and care about rural healthcare quality. We will provide links to the report for you to read in its entirety if you'd like to, as the report does have some more detailed information and some explanation and context to each element and then the whole process of developing the infrastructure. And while you see critical access hospital or COD noted through the report, the assessment in our presentation today, this content can really apply to all rural hospital quality programs. So our objectives today, like the last sessions, first we're going to look at data results, the national aggregates from the COG Quality Infrastructure Self-Assessment. We're going to talk about criteria to meet each element, and then I will encourage you to think of one intervention that your hospital can get closer to in meeting an element or meeting a criteria. So today we're talking about the last two elements in orange, collecting meaningful and accurate data and using that data to improve quality. So as we go through the elements today, I'll be encouraging some chat conversation. This is a great opportunity to ask questions of me, ask questions of your peers on the call, and really share your innovations, thoughts, and experiences to help each other. A reminder that these elements and criteria are going to be nuanced in your state or in your hospital. And really what we're trying to do with this series is give a broad overview of the elements and ways to meet criteria. For each core element, there will be 2 to 4 criteria that list ways these elements can be met or demonstrated. To meet an element, the hospital must meet each criteria. We'll also go over the variety of ways that each criteria can be met. So let's start with collecting meaningful and accurate data. To drive improvement, we really want to make sure we use our time and resources to collect data that informs the work we do and the goals we want to accomplish, and that data is accurate. The time spent on the front end of this will really save effort and efficiencies in the long run. So to collect meaningful and accurate data, we are looking at identifying that multidisciplinary approach to identify key quality metrics and prioritize complete and accurate data collection in the facility. 79% of the hospitals completing the assessment can demonstrate meeting this element. So our individual criteria for this element are really high. The lowest is the first, that the organization has a multidisciplinary process for identifying key quality metrics. And we'll talk about some ways that we can look at this process. And it's probably not as difficult as one might think. Our second criteria is that leaders identify risks and opportunities based on analyzing the key quality metrics. The organization leverages health information technology to support complete and accurate data collection. And the final criteria is the organization collects and documents race, ethnicity, and language, and sexual orientation and gender identity, often called real SOGI data, and health-related social needs or HRSN data. And this might sound familiar because yes, it overlaps with the element criteria for integrating equity and equality practices that we talked about in our last session. So criteria one, the organization has a multidisciplinary approach or process for identifying key quality metrics. And we can kind of tie this with an invisible string back to our copy requirements to some part. And the idea that all parts of the healthcare system are really interrelated. So what are some ways that we can look at prioritizing data and that we can make sure it's multidisciplinary? Um, the first is a prioritization matrix. This is an example of one matrix, but there's a lot out there. I know there's like a grid, 4 square grid matrix. This one just takes the need for improvement and then based on a variety of attributes to that, gauges the how high of a priority is. So it's just a rating scale. This one, most of them are 1 to 5 or 0 to 5. And we look at volume. If it's happening a lot, we rate it higher. If it's a high risk, we rate it higher. High cost, we're going to rate it higher. If it is being responsive to someone that the patient and family, staff, governing board has requested, we look at all that rates higher. And then we can kind of look at that in numerical format and identify what we want to start our priorities on in a very data-driven way. Another way to look at metrics is using a synergy grid. This guides us to think through our initiatives and goals and metrics to determine what parts of the system are really related to a metric and can help also guide the identification of meaningful data metrics to measure improvement. So how this synergy grid works is, for example, our goal to reduce ER wait times. The ER will be the leader of it, so there's an L there, and then we'll have a primary involvement. And so primary involvement involves the other pieces and the other systems within the hospital that impact those ER wait times. It could be the lab, it could be registration, it could be imaging. And I'd like to point out that the quality is in a supportive role. The quality is really there to be a mentor, a coach, a convener, a facilitator with the staff doing the work, being the lead and primarily involved. Criteria 2, leaders identify risks and opportunities based on the analysis of key quality metrics. So many hospitals have quality dashboards that are seen here. This criteria is also specific in CLAPI, and that quality goals should be data driven. So 100% of the hospitals completing the assessment met this criteria. Criteria 3, the organization leverages health information technology to support complete and accurate data collection. Now, I know this can be harder in smaller facilities, as I know there's less resources for IT support. You might have one IT person, if that, or maybe be reliant on the support from a system. But I'm curious, in the chat box, for those of you that have IT staff or have IT resources, how closely have you partnered with them on your data collection? Just in the chat on a scale from 1 to 3, 1 being not very close, 3 being very close, and 2 being kind of in the middle, sometimes not. Awesome. I'm seeing lots of 3s and 2s. That's fantastic. Thank you. So with so much reliance on our electronic record, we really want to harness that data that is in there to provide efficiencies and also accurate data. With the caveat, it's accurate if the documentation is done correctly and consistently. On a side note, this might be a QA project in itself, validating the data and the EHR, providing documentation to ensure the data is accurate in reports. Criteria 4, as we talked about last week, if we stratify our data in these health equity components, we really can get a fuller view of our performance. And based on the data, can identify possibly hidden opportunities for improvement. Now, when we talk about meaningful data, this also includes qualitative data, such as patient, family, and staff stories and experiences. Qualitative data gives us more context into the picture of the issue. It helps us understand the numbers that are complex pieces of healthcare. It's also a key piece in communicating our data and getting parties engaged. So how do we begin to collect this data? First, we can have a focus group. We have identified a problem. We can call in people that it has impacted or that has special skills to give input and insight and stories and perspectives. We can hold interviews. So how many of you do a readmission interview? That is the biggest goldmine in information. I have seen so many times when we're looking at readmission data and we're looking at the data and we're looking at the times and the providers and all the different pieces that are data driven, it's really hard to pull out what is happening. And so that interview, when the patient comes back to find out why or what brought them back to the hospital, is incredibly valuable. Phone calls and phone surveys, such as a discharge follow-up call, surveys with open-ended questions that give patients and families more opportunity to give more context and greater detail to their perspective, and observations, just walking around the hospital and providing observations on what you're seeing that's working fantastic, or that we might need to improve on. So now we have accurate and meaningful data. Let's use it. 63% of our hospitals completing the assessment can demonstrate meeting this element. And using data to improve quality means we're looking at internal and external data comprehensively, meaningfully, and transparently to inform quality improvement. The criteria that support this element are sharing data transparently, both internally and externally, incorporating external data sources to inform quality improvement efforts, leaders acting on and then clearly communicating data results from quality initiatives, and using benchmarking to identify where quality can be improved. So criteria 1, the organization shares data transparently, both internally and externally. So what are some ways that we can see this being done? The first is that quality initiative results are communicated to hospital staff. There may be regular reports or newsletters or bulletin boards within the facility that can do this. The second is quality initiative results are integrated into future planning on at least an annual basis. So are we looking at the current initiative, seeing how they're doing, and then assessing if we need to bring that forward and work on more, or if we are doing great and we can institute a policy, a procedure, or a process. Sharing quality metrics with the board on board dashboards. That's pretty self-explanatory. Displaying quality metrics publicly within the facility, or sharing quality metrics on the hospital's website and or social media. So here are some examples of this data transparency in action. These are boards and displays in different facilities where patients can really see, patients, staff, everybody can see what are we working on, what are we committed to, and how are we doing. This transparency really brings a level of accountability, of a shared vision, and of trust. Criteria 2, the organization incorporates external data sources to inform quality improvement efforts. So using data that is outside the walls of the hospital helps give us a fuller picture and enables us to make more accurate decision making. There are many sources out there, and I've listed a few here with links. So I encourage you to go and explore and see what's out there. Leaders act on and clearly communicate data results from quality initiatives. These are just some different ways that data can be communicated to help drive decision making. We have red charts, which are really clear. We have a stoplight report, which is where we have the green, we're in our goal range, yellow, we're kind of skirting towards that, we need to take some action, and red, we need to prioritize. And then also infographics. Those are a really fun way to get attention and communicate data. Criteria 4, benchmarking. The organization uses benchmarking to identify where quality can be improved. So benchmarking helps identify areas for improvement within your facility and across others that are similar to you. So you might have goals and benchmarks based on your internal facility prior and past performances, or you might use goals based on external benchmarks. Example, your MDQAP data reports or CMS care compare data. Benchmarking is really helpful in that we can identify best practices. When we're comparing against others, we can see who is that's doing well and how do I get there. We can set goals and targets. It can drive quality improvement initiatives and encourages continuous improvement and learning. So in the chat, I'd love to know, what do you use for benchmarking? Do you use what internal resources, what external resources? An example of an external resource we have here in Montana is there's a statewide COB benchmarking project that's been around for about 20 years or more. It is developed by critical access hospitals on data metrics that they want to compare themselves against. And it is stratified by peer groups based on hospital net patient revenue. So when hospitals receive the reports, they can see how they're performing compared to how like-sized hospitals are performing compared to how the state is performing. So that is an example of benchmarking that helps identify best practices, sets goals and targets, and helps identify and drive quality improvement initiatives. Great, Rachel has data sources in the Rural Quality Network that they belong, CMS data registries, historical performance. Thank you, Rachel and Robert. So now that we've talked through all these 9 elements, how are you feeling about them now? Thumbs up, thumbs down, thumbs to the side. Do we have a better understanding? Do you have ideas on how to meet elements that you maybe aren't meeting? Please share it. I see some thumbs up. Please share in the chat if there's any questions or how you're feeling about the core elements of quality infrastructure now. And these elements aren't just for this assessment. It's just not for data collection so that we can collect another piece of data. They truly are pieces that help strengthen quality programs, increase engagement, and in the end, ultimately improve patient care. So we have some time for questions or comments for me or your peers on any of the elements. So I will go ahead and please unmute or put in the chat if you have any questions. So I want to thank you all so much for joining me in this series. It has been really great sharing the quality infrastructure with you all. And I hope that you have found some pieces of inspiration. Your commitment to healthcare is really amazing. And thank you for what you do every single day. Please do not ever hesitate to reach out to me with questions, ideas, thoughts. I'd love to hear them. And I hope you all get some time to relax this holiday weekend and have an amazing rest of your day. So thank you so much.